Welcome to the Neuro Wellness Podcast. I'm your host, Dr. Joseph Coppus, and I'm here with my guest, Dr. Michalopoulos. Thanks for joining me today.
Thanks for having me.
Yeah. And so you wanted to go over a specific case with us today of a typical patient that you see in the office, right?
Yeah. So we treat a lot of chronic neurologic deficient patients, and so a lot of them are concussion patients. We treat a lot of pro athletes, a lot of high school kids, even car accidents, whiplash injuries, and there's an old saying old saying might be a new saying, but I heard it from a professor in Calgary that said, once you've seen one concussion, you've seen one concussion, because every single one of them are totally different, and it's very every concussion's unique, a lot of different symptoms, and so I wanted to go over a case of one a kind of a typical patient and exactly why that happens. So there's one of our patients. He was from New York. He was skating. He was actually skating with his 10-year-old son. He caught an edge and fell back and hit his head. And he went to some neurologist in New York City and said, "Well, we really don't know what to do. You got a concussion." He felt brain fog, headaches. He couldn't perform. He was a high-level, financial person, and couldn't really do his job for a couple of weeks. He went to this neurologist. Said, "Just rest for 30 days, and you should be fine." And so, sure enough, he rested for 30 days, and typically, what ends up happening is a high percentage of these cases get resolved within that 30-day span symptomatically. But what ends up really happening is your brain will compensate, and it'll compensate to avoid you being in pain, for lack of a better term. But it could be memory issues, could be brain fog, could be can't sleep or sleep too much. So your brain will compensate to help you achieve all those goals. But it's exactly the same way. Exactly the same thing as you are playing basketball. Let's say you twist your ankle and you limp on it for a few days. If you do nothing with it, that ankle more than likely will feel a lot better in a couple of weeks. And what you'll notice a couple of weeks later is you'll notice that you won't feel you're limping. But internally, your body's already compensated, tightened up certain muscles on one side, relaxed muscles on another side, kind of changed even the brain integrity to make sure that you don't feel like you're limping. But when other people look at you, they'll ask you, "Hey, why are you limping?" And you say, "Oh, I'm not limping." So it's this compensatory mechanism. So the same thing happens with your brain. I explained to the patients that, look, when you get a concussion, if it goes away and like the majority of them do, 75%. I'm not sure exactly. It's a very high percentage will symptomatically go away, and it's in the 70+% region. But what's happened is your brain's actually limped to compensate, so you don't really feel the symptoms. So now you're at you'll have the tendency to injure yourself or get these symptoms back with trauma of much lesser magnitude than falling back and hitting your head on the ice. So this is exactly what happened with this guy. He was fine after 30 days, and about 4 months later he went skiing, and it was the first run of the day, and he said he didn't even go on a hard hill. He just wanted to kind of get his bearings about him, and went down the mountain nice and easy, back and forth all the way down. He didn't fall, didn't hit a tree, didn't hit any rocks, anything like that. By the time he got down to the bottom of the hill, he ended up having 90% of all the symptoms back. And he didn't know why that had happened, so he calls a neurologist up again in New York, and he says, "Hey, I feel like I got another concussion. On what symptoms?" He goes, "Well, just rest for another 30 days. And about 30 days into it, again, he was about 40 or 50% better. And so he actually ended up presenting to our office 2 years after his initial concussion, which is pretty typical. We're never really the first people that people come to. And by the time they get to us, they've compensated. They're symptomatic. They're on medication. They've tried physical therapy, rehabilitation. They've tried visual therapy, and a lot of patients that come in here will ask, "Well, what do you guys do that's different?"
Yeah.
And we tell them, "Look, we do vision therapy. We do vestibular rehab. We do proprioceptive therapy, balance therapy. There's a whole bunch of therapies that we do, and everybody's different." And a lot of the patients say, "Well, we've already done that. Didn't work for us." And the problem is, what I see the problem is that a lot of the therapy that's done is pretty algorithmic. It's you go to some of these therapists, and they'll say, "Okay, on week 1, we're going to do these exercises. On week 2, we're going to do these exercises. On week 3, you can do these exercises. And if you're not better by week 4, they say, well, it's just going to take some time for the end of these symptoms to go away." And the problem is that a lot of these exercises that are being done are very difficult exercise to be done for the patient. Mm-hmm. And these, I call them, like penthouse exercises, right? You can't live in the penthouse if the ground floor is crumbling.
Absolutely.
So we have to work from and examine the ground floor, which is the brainstem, the cerebellum, all the subcortical structures, the higher cortical structures, and see where these highways have potholes in them, so to speak. So so what we need to do is we need to pave these potholes, and then be able to do these high level advanced exercises that will get the patient better in the end. But if you're doing exercises, we call these like ×2 exercises, where your head's going one direction, the eyes are going the other. That's a very difficult exercise for these patients to do. And if you start out there, they will not get better, okay? Because we need to start at a foundational level where we need to have them just look at a dot, and the actual doctor or the therapist do some passive exercises with them, where we can build them foundationally and then build up from there. So.
And then to piggyback off of something you said earlier, if you've seen one concussion, you've seen one concussion, right? And then when you look at kind of the standard approach being done in the concussion rehab world, like you said, week 1 you do exercises A, B, C. Week 2 you do D, E, F. So if all these concussions are different, you would want to take a much more individualized approach.
Right.
So what are some ways that you do that in your clinic?
So the first day that you come to our office, you're going to spend 3 hours here. And you've already, prior to come to our office, you've already filled out probably a 45-minute questionnaire. And we're implementing also a standardized neuropsychological test called the Cambridge Brain Sciences 2 with all these patients to see where are you exactly. These tests are about 1.5 to 3 minutes long. There's 12 of them, and it gives us a lot of feedback as to see, hey, where are you, visuospatially, where are you cognitively and memory-wise. And then when you come here, we do diagnostic tests. And diagnostic tests, we do a thing called a video oculography or video nystagmography test, which measures your ability to gaze fixate in the dark. So we have a cap on you, you look straight ahead, and the goal is have your eyes look straight ahead, okay? And what we're doing is we're recording these eyes with this cap on to see exactly can you fixate on a specific on something that's not even there. Can you just keep your eyes straight? So this tells us the integrity of certain areas of the brainstem, and if your eyes are moving, then we know, hey, there's an issue there. Okay, then we'll have you gaze fixate with your eyes open in the light. Okay, so you look at a target to the right, you look at a target to the left, you hold up, down, and this gives us kind of the perimeters of that brainstem. The certain area of the brainstem to the right called the neural integrator, on the left neural integrator, above the top part of the brainstem, and a little bit below that, to tell you exactly how well your ability to gaze fixate in certain points. Then we'll do pursuits, which will give us the kind of the integrity of your parietal lobe, but also tells us the machinery that actually controls the eyes to do those mechanisms. And we'll do what's called Saccadic Eye Movements, left, right, up, down, and this gives us the integrity of your frontal lobe. So all these what we're doing essentially is we're getting a picture and putting a puzzle together of every single corner of your brain, and wherever there's an issue, that's what we're going to treat. And there's very few times that we see a lot of people with the exact same injury. So we're getting pretty good at it right now in identifying where these issues and lesions are, and we try to just drive where it's weaker and slower, and try to inhibit where it's a little bit too fast, and try and stabilize where it's doesn't have the ability to stabilize. So there's some really good things, because that patient I was telling you about that I had alluded to in the beginning that fell and hit his head finally came here 2 years later, and he asked me, well, why did I get better here in 2 weeks, and I've been suffering for 2 years? So, and there's a very specific reason why he got better. So
yeah. So can you walk us through kind of his case and his progression a little bit?
Yeah. So he came in, and when we did the neurologic exam, you could see he was actually like very melancholy. He was very down. This guy was like a high profile, for lack of a better term, call him traitor. So, but very very intense with the work he did. And so he needed to be laser beam focused for like 6 hours a day on a computer screen, making sure everything was working appropriately. And he didn't have that. Okay, I mean, he came in, his face was drawn. You could tell that he was almost going down this this neurodegenerative highway, and we had to stop him before he started gaining some momentum. But so he came in, we did the exam, we did a full neurologic exam on him, but we did some balance testing too on him to check and see the integrity of his cerebellum, and proprioceptively and visually and vestibularly how well those areas of the brain worked, and if he'd compromised at all. So, but on the video nystagmography, the one glaring thing that we saw was that when we put the goggles on him and he was in the dark, and we said, hey, we want you to just look straight ahead. Pretend you're looking at something out in the distance. But it was pitch black that we was looking in, so he put the goggles on, and his eyes would just jump back and forth, back and forth, back and forth, back and forth. And we recorded this. Okay, so we could tell him, say, hey, look, here's the deal. Him jumping back and forth like that indicates to us that he doesn't have the ability to gaze fixate. So the exercises that he was told to do were basically too hard for him. Okay, and they were the wrong exercises. He was basically living in the penthouse, and the basement was crumbling. So so now we had to start to gaze stabilize his eyes from a foundational standpoint. And what ends up happening is the reason that all this that he was getting these headaches and neck pain and brain fog and all the other symptoms that came along with his case was from from a kind of simplistic point of view. If I turn my head to the right, my eyes will go to the left. If I turn my head to the left, they'll go to the right. If I go down, they'll go up. If I go up, they'll go down, right? So let's take a step back. Even prior to that, your brain really needs to know just two things.
Yeah.
Okay, it needs to know where you are in space. So what does that mean? It needs to know where my hands are. So if I throw a ball at you, you're going to see the ball coming, you stick your hand out, and you're going to hopefully catch the ball, right? And it's going to go right in your hand or right in the glove. Okay, well, how did your brain know to stick your hand exactly right there to make sure that you caught the ball? Well, you have these maps in your brain, and these maps have been mapped over years of experience. So this is how your eyes will actually map where your hands are, and it starts really at birth. So if you go too far, okay, and the ball hits you in the forearm, that means you really don't have an idea where your hand is. Or you go too short and it hits the tip of the glove, then you really don't have any idea exactly where your hand is. Or if your feet, you keep stumbling or tripping over your feet, you really don't have any idea where your feet are, right? So, so you need to know where all these organs and all these body parts are, so you don't hurt yourself, number one. And you also need to know where your environment is around you. So these two things, where you are in space and where space is around you, if you know those two things, then you're probably in pretty good shape. Okay. Well, the way I explain it to patients is there's really three calculating mechanisms that determine those two things. Okay. So the first thing is your eyes. Okay. So just like I said, if you move your head to the right, your eyes go left. If you move your head to the left, your eyes go right. And when that happens, what ends up happening is your eyes send a signal to your brain, says, "Hey, George is moving. Okay, is he falling? Do we need to protect him? Okay, what do we have to do?" So it goes to the next calculating mechanism, and this is going on simultaneously, but it goes to the next calculating mechanism, which is your vestibular system. And your vestibular system is a system that senses linear and angular acceleration. So what does that mean? So George and Dr. Joe are in a car together, and I say, "Hey, Dr. Joe, I want you to close your eyes. Okay, we're going down the highway here. I'm going to turn either right or left. Okay, with your eyes closed, you should be able to sense whether we turned right or left without even knowing, right? Well, there's receptors in the vestibular system that says, oh, I feel like we turned right, because I can feel my body going one way and my head going the other way, okay? So this sends a signal to your body and says, okay, well, we need to relax these muscles, contract these muscles, kind of move our body in a certain position so we know exactly where we are in space, okay? It's just like riding your bike. If you're turning to the right, you're going to have your head tilt to the left to kind of balance yourself out a little bit. You're not going to go to the right and because you're going to fall down, just like with a motorcycle, riding a motorcycle. Or if we're in an elevator, another vestibular aspect is if you're in an elevator and I say, hey, we're on the 10th floor right now. I want you to close your eyes. I'm going to push either the 20th floor or the first floor. You should be able to tell if we're going up or down, okay? Or if we're going forward and back in a car, if we're accelerating or decelerating. And all these things will cause muscle contraction, muscle relaxation, difference in proprioceptive input. And the last thing is proprioception. So you got your visual system, your vestibular system, and your proprioceptive system. So this chair here, my butt is sending a signal to my brain saying, hey, I've felt one of these things before. I know what this is. This is a chair, right? This is not one of those Three Stooges chairs that, expand, it breaks from underneath. You got to catch yourself. It's pretty stable, right? So if I turn my head to the right, for example, okay, my eyes go to the left. Your brain says, hey, is George falling? Vestibular system says, no, he's just turning to the right. Just contract this muscle over here. Proprioceptive system, what's going on? Well, he's sitting in the chair. You don't need to do anything else except contract this muscle. Everything's cool. If we're on a tightrope, okay, and you're walking on a rope, and you're going back and forth, where your head's moving, your eyes are moving back and forth, and your brain's going, hey, he's moving. Is he falling? Well, your vestibular system says, well, he's going to the left, he's going to the right, he's turning his head back and forth, you're contracting this muscle, relaxing this muscle. Proprioceptive system, what's going on? Well, we don't have a lot of stability, so we're going to have to relax the ankles, contract, get that ankle mortise to be stable, and you're trying to balance yourself. Those two scenarios, turning your head one way or another or balancing, are normal. Those are two normal scenarios. But if you're sitting in here, like we found with this patient, and he's sitting here, he's got the goggles on, his eyes are wide open, and his eyes start just going back and forth, back and forth. Remember, we said that, hey, if your eyes are moving, your brain's thinking you're moving, okay? So his eyes were moving, even though it was in the dark. This is what's normally happening, and I'll explain to you what happens after in the light, why you can't really see them sometimes when it's in the light, but when it's in the dark, his eyes are moving, and his brain says, hey, George is moving. What do we have to do? Is he falling? Well, you go to the vestibular system, and the vestibular system says he's not moving his head left, right, up, down, forward, back. We go to the proprioceptive system. Proprioceptive system says, hey, he's sitting in a chair, so nothing's happening. So what ends up happening now is the brain gets confused. And it says, okay, we think he's falling. Something's going on. His head's moving. We're not getting any feedback from the vestibular system. We're not getting any feedback from the proprioceptive system. So we're going to stabilize his head on his neck. Well, how can you do that? Okay, what's going to end up happening is there's a direct connection to this area of the brain called the cerebellum that's connected to the eyes also, and it's also connected to the paraspinal muscle in your neck. So that activates and it contracts all those neck muscles. Okay, so now this neck muscle is super, super tight, and you have now stabilized your head. You've stabilized your head on your body by contracting your neck muscles. Okay, so when patients come in after they've been in a car accident or after they've gotten a concussion or after something's happened, let's say they have a few symptoms like headaches and neck pain and nausea, and they go to a physical therapist or they go to a chiropractor, and their main complaint is neck pain. Okay, the reason their main complaint is neck pain is because this is the compensatory mechanism we're talking about, like the ankle sprain, and they're limping. Well, what happened is their neck got so tight that it was stabilizing their head on their body. So what are they going to do? If you go to the chiropractor or the massage therapist or the PT, you can complain about neck pain. So what are they going to work on? They're going to work on your neck.
Of course.
So you go to the massage therapist, and they massage you, and the chiropractor adjusts you, and the physical therapist works on your neck, and then you say, oh my goodness, I feel great. You walk out the next day, your headache's a 10 out of 10.
Yeah,
okay?
which may feel good in the short term, but then you're not actually getting to the root issue, right?
And the reason that ends up happening is because this neck tightness is the compensatory mechanism for your head on your body. So now you just totally wiped out the compensatory mechanism, that compensation to help your head stabilize on your body. And so that's why these patients feel worse after they get this type of therapy. So the key for us is, hey, look, if we can fix these eyes, okay, in this case, there's other cases that aren't eye related, but if we can fix the eyes, then we can decrease that neck muscle, and then the chiropractic and the physical therapy and the massage therapy will work, X-fold better. Because that's not the problem. Is not that you have a tight neck. The problem is that your eyes aren't able to fixate, so you're stabilizing, you're compensating with your neck muscles.
Absolutely. And I think overall you've brought up two really important points when it comes to concussion re-injury. Because you talked about earlier where you have one concussion, your brain's able to compensate, but then that little ding might set the person over. So maybe they've compensated really well, but this foundational part of the brain, isn't as stable as it should be, and it's being compensated for. You get one more little ding, now all of a sudden it just can't compensate anymore.
Exactly.
And then another big point was the fact that these areas that tell us, where we are in space are usually affected after concussion, whether it be the eyes, the vestibular system, the proprioceptive system. So now you've got aberrancies, issues in those systems, and now you're even more likely for a concussion, and you're more likely for that concussion to be even worse next time. So
it's exactly like they say, like this guy, he didn't even hit his head the second time. He just skied, and he just moved his head back and forth as he was gliding down the mountain, and all of a sudden his eyes became even more unstable, which caused all the symptoms to come back again. So, and usually it's like, if we even called this any trauma, which it wasn't really trauma, but it's trauma of much lesser magnitude to put you over the top the second time if it's not corrected the first time. I mean, we've had pro athletes from Australia, from Canada, from all over the U.S. come over, and I mean, these guys get hit pretty hard, and you see some pretty crazy number one symptoms, but number two objective findings where just when you think you've seen a lot, you've seen nothing, and then you go, holy mackerel, that's a big undertaking for us now, but a lot of them, at least we know how to approach these issues, and we've had phenomenal success with the majority of all our concussions.
Great.
And but some of them, there's a small percentage that we can't help, but at least we will know relatively quickly. The one thing we're not going to do here, at least at our clinic, is we're not going to keep you here for like 2 or 3 months and say, well, John, that didn't work. Let's run another dart over here and see if this therapy works. What we do is going to work quickly, and it's going to be, you're going to be the one to tell us as a patient, hey, look, symptomatically, first of all, these patients have no idea that objectively their eyes are moving, or their balance is off, or their proprioceptive system's off, or just all these the things that we're looking at. They have no idea that this is going on. What they do know is, hey, I've got a headache and I've got brain fog and I can't sleep. Okay, so my question to them is, if I treat you for 10 days, okay, you've had this problem for 3 years. If I treat you for 10 days, how are you as the patient going to know you're better? And they say, well, I'll feel better. And I asked them, I said, look, if I had a magic wand and of all the symptoms that you gave me, I could only get rid of one, which one would it be? And they say, oh, my headaches are an 8 out of 10. And I said, well, what do they range from, 6 to 9? And they'll say, every day from 6 to 9 or 5 to 9. And then I'll ask them straight out, and I say, look, do you know what a 2 is? And they'll say, well, I haven't had a 2 headache in a long time, but I think I know what that is. Okay, well, that's going to be our goal in 2 weeks. So if you come here for a couple of weeks and we can get your headaches down to a 2, then we're going to throw the ball in your court and say, hey, look, do you want to, if you would like to continue, you can continue. If not, then, it may take another 3 or 4 or 6 weeks of coming 3 times a week for the neuro rehab that we provide the patients for us to get you over the top. But if you come to our office, okay, I'm pretty confident that objectively we're going to make a lot of objective improvements. But you didn't come here to get your gaze stability better, or your balance better, or your coordination better. You came to get your headaches better. Okay, that's what you know. So we're going to show you. We're going to do an exam today. We're going to do all these tests. We're going to sit back down 2 weeks from now. We're going to repeat all these tests, and you will see with your own eyes on video what your eyes look like on day 1, what your balance looked like on day 1, what your cognitive ability was on day 1, and you're going to see improvements in a very, very, very high majority of the time, objectively. But if you tell me, hey, Dr. George, I can see with my own eyes everything got better, objectively, but my headache's an 8 out of 10, then we're going to X Dr. George off the list and you're out. I'm going to send you, because we can't jeopardize your health, number 1. And number 2, quite frankly, we can't jeopardize our reputation by keeping a patient for 2 or 3 months and saying, hey, that didn't work. Let's try another thing. We can't have you, saying, well, we went to those guys and it didn't work. We're going to know in 2 weeks. What I can promise you is that I don't know if we can help you subjectively, but I do know that if we do help you, like we do in the majority of the patients, that we're going to get some great results, and we're going to make you allow the patient to make the decision as to whether they want to continue with care.
Right. And oftentimes when you do see these objective findings improve, more likely than not, you see these subjective findings improve.
Yeah, that's the goal.
Follow, yeah.
We're saying, hey, look, if we can get the neurology better, then symptomatically you should get better, right? So at the very least, we're going to get the neurology somewhat better for you, okay? At the very least, okay? Yeah. If the symptoms don't get better, at least you'll know that neurologically we've gotten you somewhat better to a certain point. If you do get a lot better, then we know the neurology is working on firing on all cylinders. Your vision, your vestibular system, your proprioceptive system are all talking the same language. They're coming up and they're saying, hey, we know exactly where we are in space, and I know where space is around me, so I'm not going to trip on a crack in the sidewalk and fall down and break my arm. Okay, I'm going to be able reflexively to throw my arms out, catch myself in time, or I'll avoid falling altogether. Right. Yeah. Whereas if you don't know where you are, you're going to trip, you're going to fall, you're going to hurt yourself. So,
I know we've talked a lot about concussion and TBI today, but who are some other patient populations that you see, good results with here?
Good results. Well, we see a lot of dysautonomia patients.
Okay.
Which again is a neurologic issue, right? So it's like a short circuitry in the autonomic nervous system. So basically what the autonomic nervous system is like the gas and the brake, and the way I explain it is, you should be 90% of the time you should be in parasympathetic mode, where you're nice and resting and relaxed, and 10% of the time should be sympathetic, where you're have the gas on to make sure that all the organs are working appropriately. When you can get a concussion, you can get dysautonomia also. Okay, it's not just from usually a lot of times a lot of these dysautonomias are from a viral infection or a viral insult, but you can get it from head trauma also. And what we'll see patients that come in that have resting heart rate of 120, 130, 150 beats a minute, and they're tachycardic, their blood pressure is super low, or sometimes their blood pressure is normal and they still have a high heart rate, or they're sitting down in a chair and their heart rate is normal, and they stand up, it goes up 30, 40, 50 beats a minute, and that's not normal. It doesn't come down fast enough. So there's things that we can do from a neurologic perspective to kind of recalibrate the autonomic nervous system, and help these patients with dysautonomia and fatigue and poor sleep or too much sleep, not enough sleep.
Yeah. And I'm sure we could do, and I'm planning to do a whole show on dysautonomia actually. So we're going to get much deeper into that. But great. So something I'd like to know is how did you end up getting into this field? What led you down this path? So
that's an interesting story too.
Yeah.
So the office we're in now, I just moved into this office. It was January. It was actually the first week that I moved in here. I've been practicing down the road, about a mile and a half down the road, and we were down there 15 some odd years, more, maybe 17 years. And we opened up a new, bigger office here. And I saw some flyer come in the mail that talked about, do you want to treat concussion? It wasn't concussion. It was actually, do you want to treat, how would you like to treat migraines and anxiety and tics and Tourette's, and a couple of other neurologic issues that were on this flyer. And so I looked at this and I thought, we've spent a lot more money on seminars that have given us a lot less. So I actually called this guy up and I said, hey, what's this all about? And he told me, he said, look, this is, he told me he's a chiropractic neurologist and he's teaching this course. And I asked him, I said, look, just straight out as a colleague, is this legit? And he said, George, he goes, what you're going to do is you're going to take my course and I'm going to teach you everything you need to know. And then if you don't think that I taught you what you think this is worth, I'll give you a refund all your money. And the reason I even did this is because my daughter, my oldest daughter, had Tourette's, and I thought, well, geez, this is something that maybe I can help her with. So I ended up taking this course, and it was just binder and a couple of basic things, and I ended up basically memorizing the course, and it was 1,100 pages of notes. And I called the guy up and said, hey, I can teach this course right now. What do I do next? And he said, well, what do you mean? What do you do? What do you want to treat? And I said, well, at that point, it was like 17 years into practice, I always had difficulty treating migraines. And I would, every time in the beginning, I would try and treat the migraines, and I had like a very low success rate with migraine headaches. So I said, I'd love to treat migraines. And he says, okay, this is what you're going to do. You're going to call up, the 5 hardest migraine patients you've ever had, and I'm pretty sure they still have their migraines that you referred out, and call them in and tell them you'll treat them. Okay, I want to treat you for 2 weeks. So I actually had one lady, she was a friend of ours, I brought her in, and she would have, in 30 days, she'd have 20 days of migraines, okay? 25 days of migraines, 20 of those days she was in bed. Okay, so we never saw her because of these migraines. They were debilitating. So we brought her in. She had her black glasses on, and she goes, "Oh my goodness, my head's pounding." And she would take this medication that was a migraine medication. And a lot of times she'd take it prophylactically. She didn't even need it, but she was so afraid that the migraines would come on. She just kept taking these pills. So we ended up treating her for about 2 weeks. And by the end of the 2-week program, her headaches it's actually 17 days for her. Her headaches were gone. And she was coming in complaining of knee pain. So, when are you going to fix my knee pain? I go, "Hey, how's the headaches doing?" Yeah. And she goes, "Oh, they're gone." And she forgot she had it for 27 years, 20 days a month in bed for 27 years. And so then I called this guy up, the guy who taught me this stuff. I said, "Man, this is like crazy." And he's the one that told me, "George," he goes, "what I taught you is like the tip of the iceberg. This is nothing. You need to go to this guy named Ted Carrick and have him teach you." And so I said, "Well, I've never even heard of this guy before." And so he said, "Here's the name, here's your number, call him up and tell him I referred you and they'll take care of you." So basically for the last 10 years, I would pretty safely say that for the last 10 years, 4 to 5 weekends a year, I'm out of town learning from Dr. Carrick and the Carrick Institute. So,
excellent.
Yeah.
Excellent. And it's showed and paid off in the clinic, everybody, I'm pretty astounded, how fast people tend to get better. And yeah, it's great
like
stuff.
Migraines are like baby food now compared to like 10 years ago. Anytime somebody called about a migraine, I'd give them the name of the neurologist. I'd just go down the road to the medical neurologist and he'll either give you medication or do whatever he wants to do with you.
Yeah. Well, this was great, Dr. George. Do you have any closing remarks before we
I just
sign
think
off?
Honestly, now we get patients that come in, or actually we actually do these phone consults where we'll talk to patients, and they'll say, "I have this problem," and sometimes I got to look them up on Google and say, "I've never even heard of this before." But if it's a neurologic issue, at the very least, we can, do a neurologic exam, see which one of these highways are have potholes in them. Let's try and fix it. We'll try it for a couple of weeks. If you get better, you get better, and we'll throw the ball back in your court and say, "Hey, look, do you feel like you got better? If you do, then we'll continue. If you don't, then we'll X the clinic off the list." And you can X this, chiropractic neurology off the list, and you can go on the next path. But usually the problem is by the time they get to us, is they've already been to 30 or 40 doctors. We've had patients that have been to 40 doctors before they get to us. So
yeah. Okay. And if any of these patients wanted to find out more about you, about the clinic, where would they do that?
They can call the office. The office number is 630-766-1552, or go to our website at neurowellnessinstitute.com. NEUROWELLNESS Institute INSTITUT .com. That's it. And the phone number is 630-766-1552.
All right.
Yep.
Well, thank you very much, Dr. George. This was great. And then this has been your host, Dr. Coppus, signing off. Be well.